focused talks on the webisode series. So first, I would, request Dr. Nikhil to invite and introduce Dr. Rajneesh sir for the first talk. Dr. Nikhil, please.
Thank you, Dr. Shefali. Welcome, Dr. Rajneesh, welcome, Dr. Gupta, welcome, Dr. Singla, and welcome, Dr. Madhusudhan. So this is a webisode targeted mainly at students, and the topics we have accordingly kept the basics of pancreatic cancer. So the first will be by Dr. Rajneesh, and he will tell us about diagnosis and workup of pancreatic cancer from a student's perspective. Right. So Dr. Rajneesh is professor of surgical gastroenterology at SGPGI Lucknow, and I have the fortune of training under him for a brief period of time when I was doing my non-acad SRship at SGPGI, and he is a clinician, academician par excellence. So let's welcome Dr. Rajneesh. Sir, over to you.
Yeah, hi, good evening. Am I audible?
Yeah.
I hope clearly so, is it? Okay, thank you, Nikhil, for this kind invitation. And I'm assuming that I'm addressing residents from Max alone, or is it Pan-India?
It's Pan-India, sir.
Okay, so we have about 36 people here, right? And obviously the talk is centered around addressing what the residents would do on a bedside basis, right? So greetings to everybody, the eminent faculty. And I can see General Atul Sharma here. Sir, good evening. I didn't know you were part of Max. Am I audible to you? Sir is still muted, right? Doesn't matter. Okay.
Sir, you can unmute. Dr. Atul, sir, you can unmute.
That's all right.
Hello.
Sir, good evening.
Hi. I'm not in Max, yeah. As she told you, it is Pan-India. I am sitting in Chandigarh.
Right, sir.
And working in ICAP.
Great to see you, sir.
I saw this poster and I thought, let me, talk to old friends after a long time.
We'll benefit
so how
from
are you doing?
I'm doing well, sir. Thank you so much. So getting into the talk now, the brief given to me was, where do I share? How do I share? I get lost all the time. After so many things, I still get lost. Where is the share button? I don't see a share button.
Shubham, can you help, sir, in sharing the screen?
Yeah, sharing button, you will get it at the middle of there's a row below the screen you can see. So it's
the green
color, sir. The green color.
Right. Okay.
Share screen. Yeah.
Okay. Yeah. So the talk was geared to address actually a bedside clinician's perspective rather than be an all-encompassing, all-comprehensive talk of what diagnosis and workup of pancreatic cancer should be. And I can see that following me are two eminent faculty members speaking about imaging as well as EUS, so that takes away a lot of load from me. So I will talk about a few specific points. Most of it has to do with clinical medicine. Some bit of it is essentially derived from the fact that I do have the opportunity to be an examiner as well as witness exams for a lot of DNB MCH candidates, and I realize where all people get stuck in terms of answering questions. So most of the talk is geared to more of a bedside perspective of how history and what points should be entertained. Before I start, I must confess that we, at least in our country, pay a lot of emphasis in the examinations as well as in the clinics to a good history and examination. That is probably not the case in most of the Western and developed nations. And the reason for that is that most of the history and examination is riddled with pitfalls. So you can have a perfect diagnosis by the end of your history and examination and you will be totally off mark. It is not the fault of the history of the examination. It is a pitfall which is basically the fact that you are relying on a witness, that is a patient, to give you a history and then your own senses to give you an examination, and you can be totally off the mark. That doesn't mean that your approach was wrong. That essentially means that you have to realize that the process of history and examination is essentially to objectivize what you see in front of you and then keep on doing course corrections as you grow in your experience from residency to faculty and thereafter senior faculty. So I'll just touch upon a few points. So essentially, these are the broad headings of what I'm going to cover. Clinical presentation, a few bit of CA19-9 pitfalls, basic workup. I was told to cover tissue diagnosis as well, and a fair bit about pre-op drainage, where we get stuck and what does literature say as of today. So when we talk about clinical presentation, this again is not all comprehensive slide, essentially points where discussions usually center both on the bedside as well as in examinations. And maybe I missed out a few points. We can discuss those in the Q&As. Obstructive jaundice. So the bottom line is, if the patient has progressive jaundice with clear-colored stools, pruritus, and high-colored urine, what you're dealing with quite likely is malignant SOJ, and in a very high likelihood of what we are presenting here, is going to be pancreatic cancer. The differential diagnosis of this particular scenario in the north part of the country is definitely carcinoma gallbladder, and of course periampullary carcinoma and cholangiocarcinomas of the lower CBD also play up. Cholangiocarcinoma is usually unusual diagnosis because in the frequency it comes out low. So, but it is there. But top of the list in this kind of a scenario where it is progressive, clear-colored stools, pruritus, and high-colored urine would be pancreatic cancer and gallbladder cancer in some parts of our country. And in the history, obviously, you'll have to draw out points which tell you that the jaundice is obstructive versus liver disease. So you have to talk about prodrome, encephalopathy, GI bleed. If they're absent, you say that in as many words that they have not been found in the particular patient in history taking and all that. And in signs, you have to be clear that you have looked for, even if they're absent and the patient is a very clear case of a malignant obstructive jaundice, you have to talk about signs of liver failure, whether they're absent or present. A lot of examiners do make a big deal about not calling it surgical obstructive jaundice, because apparently the classical dictum used to be that pancreatic cancer is surgical obstructive jaundice. The reason for that is essentially that quite a few of these patients, the majority of these patients are not surgical patients. So quite a few senior examiners might get at you saying that, how can you call it surgical obstructive jaundice? It is obstructive jaundice, all right. You can call it malignant obstructive jaundice, but you can't call it SOJ in the classical term, unless you have shown it to be a surgical patient. And this is again a point which people get stuck at very often, especially the young residents. The classical history in the textbook, even today, of pancreatic cancer is a painless progressive obstructive jaundice. Unfortunately, quite a few of these patients do have a history of pain. Now, that does not mean that that is not a classical history of pancreatic cancer. What it means to say is, if the patient has painless progressive obstructive jaundice, the likelihood of a malignant obstructive jaundice is very, very high. And in that scenario, the frequency is pancreatic cancer and gallbladder cancer on the top. But quite a few of these patients, frequency can be as high as 70–80%, do have pain of some sort. It can be pain which is dull aching, visceral pain, or it can be deep gnawing pain, which is very severe and the patient is doubled up in front of you. Regardless, the positive predictive value of a painless progressive jaundice would be very high for a malignant SOJ. I decided to dig through literature and decided to figure out as to how many patients do actually have pain. And the figure is very widely variable. As large a figure as 80% to as small a figure as 30%. So you can fit your patient anywhere in between. This is important because quite often in the exam, when you have painful obstructive jaundice, then the discussion starts centering around, if it is pain, then you must consider gallstone disease or benign obstructive jaundice to begin with. But again, bear in mind that quite a few of these patients do have pain in pancreatic cancer, and therefore, even if it is painful obstructive jaundice, it does not take away from the fact that you can still have a malignant obstructive jaundice of the pancreatic cancer type. The causes of pain are important, and the reasons for this, you have to realize that some of these causes of pain do have implication on your treatment as well. So while mass effect, perineal pain is important, but postprandial pain due to secretory pressure in the gland possibly can be relieved to a certain extent when you supplement exocrine enzymes. And gastric outlet obstruction, again, has to be figured out during the examination. Of course, there'll be other features as well, but sometimes pain is a dominant feature and vomiting comes out only when you actually ask the patient about the vomiting. What are the implications? Now, this is important. Severe pain is usually uncommon. Patient usually has visceral pain and can have some radiation, but severe pain is essentially uncommon and is usually a harbinger of poor prognosis. It is important to understand that when patients have painless progressive jaundice, usually fits into an early stage of pancreatic cancer. When they have painful obstructive jaundice and it's pancreatic cancer, usually it's locally advanced or metastatic. But this is not an invariable phenomenon. Quite a few patients who have painless progressive jaundice can have quite advanced disease and vice versa. Nevertheless, we have some data to say that patients who have no pain or less pain have a better prognosis because of a lower stage of disease. Again, a lot of discussion sometimes centers around diabetes and pancreatic cancer, so I thought I'd touch upon this. In the history itself, long-standing diabetes is a modest risk factor, and literature has borne us out in a very, very long span of years to say that the risk stands at around 1.5 to 2 times. And possibly this is not related to any confounding factors. We still don't know why it happens, but patients who have a long-standing history of diabetes, in the literature it is said more than 5 years is long-standing, do have a prediction for higher risk of pancreatic cancer. And in the same breath, apparently there is some literature to say that some of the oral hypoglycemics may protect you. For example, metformin does protect you from pancreatic cancer. Large population-based studies say so. And new onset diabetes is a harbinger of pancreatic cancer. It can be a marker of the pancreatic cancer itself. Again, population-based studies from the West tell us that from the primary healthcare perspective, if you have a new onset diabetes, it may be a risk factor for screening that patient with pancreatic cancer in their social circumstances. And when you say new onset, usually the time frame given is about 2 times and the risk is about 8 times. Other aspects to this. It seems that new onset diabetes may be actually a paraneoplastic syndrome. And there have been some molecules which have been identified to cause insulin resistance, which are produced from pancreatic cancer, and therefore it is labeled as a neoplastic phenomenon. And the caveat of this is that when you resect the tumor, you may actually resolve the diabetes if it is new onset because of the paraneoplastic syndrome. It happens in a small minority of patients. The other aspect is that diabetes is known to cause, to be related to increased surgical complications. So therefore you have to take a good history of what kind of diabetes, how long, what is the patient taking in this kind of scenario. And we have very nascent data to suggest that in pancreatic cancer, diabetics may have worse long-term survival, oncologically speaking. We still don't know why. It seems there is a correlation, although the correlation is still tenuous. Anorexic weight loss, again, important. The causes are usually a cancer-related cachexia. It can be obstructive jaundice. It can be gastric outlet obstruction. It can be exocrine insufficiency, or a compendium, or a correlation, or a kind of multifactorial cause of anorexia and weight loss. And this is important because quite often malnutrition with obstructive jaundice is treated by trying to relieve the obstructive jaundice by a pre-op drainage, hoping that the patient will improve and gain weight because the appetite may improve. It may not be invariable, but this is listed here as a cause of part of the anorexia and weight loss because it is correctable, at least to a limited extent. What is significant weight loss? Again, people do get stuck. So at least there was a international panel of experts which got together and said that weight loss, and this applies to most malignancies now, of more than 5% over the past 6 months. And they had other caveats as well, BMI less than 20 and any degree of weight loss over 2%, or appendicular skeletal mass muscle index, which is consistent with sarcopenia. These are all parts of definition of cancer cachexia. This was part of an international panel of experts which tried to put a definition to cancer cachexia. Now this is important. There's a trial which is ongoing right now. The protocol has been submitted a couple of years back, I guess. This is to tell us what we do on the bedside all the time. This is addressing exactly the same issue. The patient comes to us, patient is at least imaging wise resectable, but patient doesn't seem to be fit for surgery. This is what we address. We have often addressed it by rehabilitation in terms of exercise and physiotherapy. We address it by giving nutrition to the patient and add to this anti-inflammatory medication, because apparently inflammation is a part of cancer cachexia, which seems to be well addressed in literature. However, it still remains to be seen whether anti-inflammatory medicines can reverse a part of it. So this is a manic trial. Results will be very interesting because it is essentially addressing what we do on the bedside all the time. But we really don't have any objective data to say that actually works. again, seems to be a very minor part of the history taking, but it seems that depression and other psychiatric symptoms have been very widely studied in psychiatric literature, psychiatry literature across the world. Not so much in the surgical literature, but this plays a role in when you you're faced with a patient who doesn't want to get treated, and you know the patient is susceptible, or at least can come to surgery if you can address a part of the malnutrition as well as related to it, depression. It seems that there is a fair bit of correlation between pancreatic cancer and depression and other psychiatric symptoms as well, dominant of which is depression. And there is a mechanism postulated in psychiatry literature, which is altered serotonin metabolism. It seems that it may be actually a paraneoplastic syndrome, because quite a few of these depressions do get treated after the patient is resected. And hence, the implications are that treatment of this depression may have positive this thing in addressing cancer cachexia and needs treatment for building up patients for surgery. Again, these are simple bedside history taking, which often we ignore and don't address. And sometimes examiners and even on the bedside, you may find useful for use of this. We are aware of the Trousseau syndrome, and hence we forget that pancreatic cancer actually has a long list of paraneoplastic syndromes, which a very well-read examiner or even you may have to see an occasional patient, and you may forget to see them. So you should be aware of a long list of skin lesions, even myasthenia at times, neuropathies, and even diabetes, which is new onset diabetes, which seems to be a paraneoplastic syndrome. Acute pancreatitis, we are not talking about IPMN. Even the absence of IPMN, in large registries of pancreatic cancer, 5% of patients do have a past history of acute pancreatitis, documented acute pancreatitis. It's possibly to do with ductal obstruction, but we still don't know the reason as to why, because this is essentially an association. And large hospital admission data of acute pancreatitis suggests that about 1% of these patients may turn out to be pancreatic cancer. Again, figures which help you on a bedside as well as cheekily in the exams. It's important to address family history, especially when you have a young patient. And in Indian scenario, sometimes we do get these patients. And be aware of which are the familial syndromes which have a high risk of pancreatic cancer. Peutz-Jeghers is one, which has a very high risk. Again, HNPCC has a reasonably low risk, but needs to be addressed. And then there are familial syndromes like the FAM syndrome and familial breast and ovarian cancer syndromes. So a good personal history, family history is important. A personal history, I'm going to just mention that smoking is a very important history, both for the etiopathogenesis as well as for the treatment of the disease itself when you are contemplating major surgery. Alcohol is still a very tenuous relationship with the etiopathogenesis, but very important when you talk about your workup for taking the patient to surgery. And again, the examination findings. Just spend a couple of minutes on something which people do stumble, both on the bedside as well as examination. What exactly is this? Is essentially general surgery, but this recapitulation, because often we forget actually what did he actually say and how do we interpret it. All he said was that if you have a palpable gallbladder, it is probably not stone disease. That's all he said. I didn't mean to say call it a law, because even in his own series, there were a few patients of gallstone disease who had a palpable gallbladder. And in Corvose's own paper, he wanted to say that this possibly is because of recurrent inflammation of the gallbladder because of stone disease, and hence the gallbladder shrinks. However, subsequent research by several authors in the last few decades, people have nothing better to do, found that gallbladder pressures are high, and hence gallbladder does not distend because the stone obstruction is intermittent and partial. And so the usual interpretation of this is that since the malignant obstructions are tight and complete, and then hence the gallbladder is palpable. But his original paper did not mean to say that at all. Exceptions, again, favorite questions. So hence I'll just put a list here. Not palpable. Well, patients usually have undergone ERCP and you forget that you actually taken the history, and when you are asked as to why it is not palpable, you forget about it. The obstruction may be proximal to the cystocolic, which means the patient actually has a cholangiocarcinoma. Past history of cholecystectomy, you may actually have given the history to the examiner, and when he asks you why the gallbladder is not palpable, you forget about it. Enlarged liver, at times the gallbladder is hidden under the liver and it's not palpable. And sometimes concomitant cholelithiasis causes the gallbladder to shrink and you may not be able to feel it. and the other way around. Gallbladder is palpable, but the patient has benign disease. Double obstruction, chronic pancreatitis, parasitic obstruction, congenital cholelitical cysts, and apparently some patients of case reports of AIDS associated cholangiopathy had palpable gallbladder. So useful list for people who intend to take on examinations, right? CA99, again, does come up in the exam and the bedside sometimes as discussion points. So I just want to address a few points. It is essentially what happens is that in pancreatic cancer, in normal pancreas, the glycosylation of molecules is an important part of intra- and intercellular signaling. And when the glycosylation is unregulated, as in a pancreatic cancer cell, that's when you get the molecule which is CA99. Essentially, it is silated blood group antigen, which is not specific to pancreatic cancer. It is found in a lot of biliary cancers and other cancers as well. It's important to understand that there are about 10% approximately patients who would be Leos antigen negative, don't express the antigen, and hence they cannot have CA99 expression at all, even if they have pancreatic cancer. So this is a false negative interpretation. Now, what are the ways you can use CA99? Remember that CA99 production and expression in the serum is dependent on a large amount of pancreatic cells, cancer cells producing the molecule. Hence, it is not a very useful test in diagnosis of early small tumors. Hence, it has not been included in screening protocols of high-risk patients across the world. Then there are a few screening protocols about patients who have either familial syndromes or other high-risk features where screening has been put into place in the developed world. There, it is MRI and EUS, which has been it is first-line form of screening. CA99, because of this particular issue, is not part of it. Is a very low positive predictive value, and it's not part of screening protocols unless you have a suspicious lesion. Diagnosis, it seems that sensitivity specificity is very high. So if you have a value which raised more than normal, likelihood of, and of course in an appropriate clinical scenario, likelihood of having pancreatic cancer is quite high. The other molecule which has been studied as a tumor marker in pancreatic cancer, and there are other as well. The more common one is CEA. And remember that the sensitivity of CEA is fairly low. It's about 50% or less, and hence it's not used in clinical practice. And there was a score proposed by, I forget the name, I think, wherein you have a compilation of CA99 and CA value, and was found to be slightly superior to CA99 value alone in diagnosis of pancreatic cancer. The other way it is used, the value of CA99 is used for prognostication. The normal value is less than 37 international newspaper later. And when it's elevated, it is a poor prognostic marker. And when it is elevated very, very high, then the prognosis is even worse than a patient where it is only slightly elevated. The problem really is that several studies have tried to give us a figure of what is very, very high. And we often fall flat in discussions when we say one person calls more than 400 very high, the other person calls more than 1,000 very high, the third person says 120, because different studies have used different cutoffs. And hence, you're perfectly right in saying that's high, but I really don't know what is very, very high. The other place it is used and it is well validated is in monitoring treatment, especially in metastatic setting, wherein the extent of fall is correlated with prognosis. So if you have a patient where the CA99 responds very well, the patient probably is responding very well to your treatment, even if your imaging does not correlate with the CA99, and that patient will probably have a better prognosis, and you have a Kaplan-Meier chart which shows you the same. Follow-up, a bit controversial because its role in post-treatment surveillance is not clearly defined. Now, if it was high, it's common sense to say that let's follow up in the post-op period, post-resection period, or post-treatment period. However, it seems that while it will be useful to follow up, but detecting the tumor by using CA99 does not give you any lead time to improve survival. And hence, NCCN, while NCCN recommends that you should have regular surveillance with CA99, the European Society of Medical Oncology does not recommend, because apparently there is no routine follow-up and it does not add to improvement of prognosis when you pick up the tumor using CA99, a recurrent tumor using CA99. The last bit, which often is a tripwire, is that CA99 also increases in patients with benign disease with obstructive jaundice. And so there is a problem, because a lot of our obstructive jaundice patients with pancreatic cancer also have increased partly because of the obstructive jaundice itself. And hence, some form of adjustment needs to be done for the degree of jaundice before you interpret the value. And that's where literature really fails us. Several forms of adjustments have been described, but there is no universally agreed adjustment factor. The most commonly addressed and used is usually a ratio between 60C and 99 and bilirubin. Unfortunately, using this ratio, people still don't agree on what should be the cutoff. Should we still use the same range as the normal value, which is less than 37, or should we increase it to 90 or so, where some publications have said that you should use a value of 100 IU per liter when you have a ratio of this sort. Nevertheless, if it is very high, your jaundice is not making much of a difference. It is only when you have benign disease or you have a low value that you need to adjust for jaundice. Basic workup essentially is fairly routine. I'm not going to address it in detail at all. Suffice to say that you should always have ultrasound and chest X-ray in your kitty before you ask for advanced imaging. And why do we say this all the time? Because pancreatic cancer is advanced and metastatic in a very large number of patients, even before, at the first presentation to the clinician. And hence, if you can diagnose a patient with ultrasound or chest X-ray as a metastatic disease, really not much role to go in for advanced imaging. And of course, you may still ask for it later on, but at least you can prognosticate the patient much better than at that point in time. And this seems to be something of a lot of people in the exams as well. I think this will be covered when we have a faculty talking about imaging. I wanted to touch upon these 2 points because NCCN seems to suggest, and again, some people have the misconception that both of these are routine parts of workup and treatment of pancreatic cancer. Well, that may seem common sense that you have a tumor which is very aggressive and hence you should add both of these, both a PET scan and laparoscopy. But it seems that at least NCCN and quite a few other societies do not routinely recommend. They recommend this only for patients who are high risk. The problem is the definition of high risk seems to be very wide. And we have large tumors, I think MD Anderson said more than 3 centimeters, or bulky lymph nodes, or patient going for neoadjuvant therapy, or patient has a high CA19-9, or suspicious lesions on CT scan when you ask for both of these investigations to improve the prognostication. Why we don't ask for them in any other patient? Well, it seems that tumors which are lesser advanced, both these do not add much in terms of cost savings and improved staging, and hence they are not added in most of these patients which do not have high risk features. Tissue diagnosis, I'm talking about pancreatic cancer alone. We are very clear on this. There is, if your imaging is appropriate, is clear and is classical, and you have appropriate clinical scenario, then there's no need for tissue diagnosis before you offer further for surgical therapy in these patients. And even then, you should understand that's very small minority of these patients, the PD specimen, even in a classical imaging scenario and a clinical scenario, may still turn out to be benign, and that has to be addressed when you take proper consent from the patient. Having said that, there are some indications for tissue diagnosis. These are some of them. These are not universally agreed upon. Some of them are, well, patients who are going to undergo some form of neoadjuvant therapy or have metastatic disease, not going for surgical therapy. There is an atypical mass on imaging where you have the enhancement pattern or the mass is not very clear. So there's a reasonable doubt in diagnosis. You may want a tissue diagnosis, or the patient is not fit for surgery, even though imaging shows us that it's a resectable tumor. You may ask for a tissue diagnosis. And then there's a set of patients which is increasing by the day, where the patient says that, so what if the CT says a mass, I want to have biopsy. And you are forced at times to ask for a biopsy. So what is high suspicion? What would you consider as, all right, imaging is good enough, let me go ahead and operate this patient? That set of criteria is not very well defined. It is more based on a high suspicion on a bedside or a clinical ground. Some publications try to define it, and this is some of them. So you have other set of features also, you can define it, but a compendium of weight loss, high bilirubin, increased CA19 and a mass would be very, very high suspicion, wherein you don't need a biopsy. The problem is it doesn't tell you what happens when you have weight loss and you have a mass, but you don't have a jaundice patient. Or and you have a high bilirubin, but the CA19 is normal. So that's where judicious clinical judgment on the bedside is important. And hence I said that indications for tissue diagnosis will be slightly widened depending on the clinical scenario you are facing. How do you do it? I think people after me will talk about this more in detail. But FNAC and core biopsy seem to have essentially the same accuracy, with core biopsy having a slightly more complication rate, and the sensitivity, specificity, accuracy is fairly high, close to 90%. Okay, we come to a point I was asked to address, pre-biliary drainage, because it seems this is again a stumbling block, both in the bedside as well as in the exams. So we have a long list of problems we have understood from historical articles, that what the problems biliary obstruction and deep jaundice cause. And we know we have been through this times again from MBBS days up to MCH, and they still seem to be cropping up again in exam as well as in the bedside. So we have effects on the biliary tree, we have effects on the liver, mucosal barrier, cardiovascular function, renal function, immune function, coagulation, and wound healing, and there are probably a few I've missed out in this list as well. So which means to tell us that biliary obstruction and high jaundice seem to have some problem when you have to address these patients with surgery. And so how do we have been addressing these patients with high jaundice with some solutions in the perioperative period. And we usually use good IV hydration because we understood that there's probably no cardiac repressive factor. It's probably all to do with poor volume status of the patient, so IV hydration. And since the gut mucosal barrier is usually weak or breached and there's endotoxemia, so antibiotics do have a role. Again, renal dialysis, some people still continue to use. In my residency days, we have used mannitol, but no longer so, because it seems that just volume correction is good enough to give you good urine output. Again, I've written dopamine in my pre-operative charts as an intern as well as a junior resident in general surgery way back, and it seems today now that's history, no longer used. And again, careful monitoring of volume status seems to take care of most of the issues people face in operating patients with deep jaundice. So it makes sense that if you have such a lot of problems you have to address, then why not just drain the biliary tree and to reduce the bilirubin before you operate? Yes, conventional wisdom. Unfortunately, draining the biliary system seems to have brought us a new set of problems. And these are well documented problems now. There's an increased risk of having bile cultures, and we have increased risk of infective complications. Absolutely no controversy in this. World over, each and every surgeon will tell you, yes, these are facts. Whether they are clinical problems or not is a different matter altogether, but they are facts. So we have huge number of trials, randomized also prior to this, and a large number of retrospective cohort studies before we came to a good study done by the Dutch, and we have to rely on the Dutch always to give us good studies. This was about 10 years back. The DROP trial, and I suggest that at least the younger lot do get familiar with this, because this crops up again and again when we have a discussion of pre-op drainage in the exams and even in the bedside. So it said that when you drain the biliary system or you don't drain it, there is no difference in the complications related to surgery. But what definitely did happen was that the drainage itself caused more problems. And therefore, we had problems related to the ERCP drainage, meaning to say bleeding, pancreatitis, sepsis, related to the drainage itself. Hence, it seemed like a bad idea to drain the biliary system given this trial. But there was a problem. And the problem was, these guys never saw patients that we saw. Their maximum bilirubin in the study was 15 mg%. And we are used to seeing patients above 15 all the time. So can we use this information to address pre-biliary drainage in our patients? The answer is obviously no. So then what do? It seems that quite a few surgeons give you these observations again and again that when you operate patients with high bilirubin, 15, 20, 25, 30, and there are people who still operate them, tissues seem to bleed more. They're not as good. And so bleeding complications seem to be higher. And we from SGPGI have documented this long time back, and others have also documented this, that when you operate patients with deep jaundice without doing pre-op drainage, hemorrhagic complications seems to be higher. Now you can always debate as to what is the cutoff you use, but this seems to be observation by a lot of surgeons that hemorrhagic complications are higher when you operate patients with deep jaundice. What is deep is open to debate. In that particular study, we had used a cutoff of 10. Today, probably it's not tenable, but nevertheless, deep jaundice does cause problems. So it has probably a role in selected patients. The problem is selecting those patients. There are some absolute indications, cholangitis and planned neoadjuvant therapy are probably most people would agree that these are absolute indications for biliary drainage. And there are a set of relative indications which work in sets. Usually no patient has a fulfillment of only one criteria. They work in sets. We need to say that you have a patient with malnutrition as well as he doesn't have money. A patient has uncontrolled diabetes and he is malnourished. Or patient has bilirubin which is 25 and he has a BMI of 15. So soft indications work in sets. So you want to use them to postpone surgery. Now I put what is very high bilirubin as a number there. This is open to debate and questions. There is no real answer to this question as to what is very high bilirubin. And each surgeon works with his own experience. But I would guess, it's a wide shot, that 20 would be acceptable to most of us. So how do we drain them? Plastic drainage, PTBD used to be the endoscopic stents by plastic stents, and PTBD used to be the norm earlier. And SEMS has made inroads and seems to make sense that plastic stents do get blocked because they're very thin. So a wide bore SEMS, even though the cost is a concern, probably will take away that issue wherein the biliary system gets blocked in the stent and you have cholangitis. And this was a cohort of patients with the DROP trial progressed to offer us. So they went ahead using the same cohort of patients from the DROP trial and added a cohort of patients from there onwards in which SEMS were placed and compared the two and found that patients who had SEMS placed had lower risk of complications. In fact, the risk of complications in patients who have pre-op drainage and SEMS was similar to patients who did not have any drainage at all. So it seems that SEMS was the way to go. We have two recent randomized trials which give us comparison between plastic stent and SEMS. Although there was no difference in the complication and rates and outcomes, and these are randomized controlled trials, so they are fairly well done. However, the Swedish trial did tell us that the block rate and the exchange rate or re-intervention rates with SEMS is definitely lower, even though when you add re-intervention to these patients in plastic stent group, the total complication rates seem to be similar to SEMS. So I think a takeaway message can be that when a patient can afford a SEMS, and these are, by the way, fully covered metal stents, then possibly that may be the way to go. Of course, more work needs to be done on this issue. So I think I've, okay, this is again an issue I wanted to cover. Last bit, quickly, what should be the pre-op duration of drainage? Again, question which crops up again and again. I've drained my biliary system, now how long do I wait? It seems that molecular studies from animal models have told us that cellular changes may take up to 6 to 8 weeks to reverse. That's not the kind of time you have when you're dealing with a tumor like pancreatic cancer. So can we shorten this? So too much delay is probably not advisable. So what does literature say? Should we shorten it? It seems that a lot of people are following various numbers. And let's not look at retrospective cohort studies. Let's just look at randomized controlled trials. What do they say? DROP trials seem to say that the delay should be 4 to 6 weeks. The mean time was 5.2 weeks. There was a Swedish randomized trial. I just alluded to that, plastic stent versus metal stent. And therein the mean delay was 36 days, which is about 1 month, which is about 4 weeks. And the Koreans apparently have their own way of going about it. They seem to disagree with everybody, and they seem to believe that we should operate within 2 weeks because apparently beyond 2 weeks, the risk of complications is high. And two major cohort studies, retrospective studies, give us exactly opposite conclusions about this particular aspect. The Italians found out that when you segregate these patients in 3 categories, it seems that operating patients within 4 weeks leads us into more post-op complications. And these are patients who have undergone pre-op biliary drainage. And so therefore, operating after 4 weeks does not have any more complication rate, as well as does not worsen any kind of survival in this particular study. The Koreans believe their own study, and this is why they believe it, that if you operate beyond 2 weeks, it seems that the stent gets colonized much more often, gets blocked more often, and hence you have more post-operative complications. And they seem to believe that less than 2 weeks is a good idea. So what do we do then on the bedside? Again, a confusing question. So the last slide, it's probably reasonable to offer a 4-week delay. However, it is not a figure laid out in concrete. It should be guided by what was the indication of pre-op drainage. So you may have a patient where you have bilirubin for around 10 or 12 or 13, but the patient had a BMI of 14, 15, and you thought that let's wait for a few weeks, let's get his albumin above 3, let's get his body weight added on by another 5 kgs, and then I'll operate the patient. You could come to that point after 2 weeks, because at 2 weeks or 3 weeks maybe, the patient may have added 5 kgs weight, his bilirubin may have come down below 5, you don't need to wait any longer. So hence, the delay after pre-op drainage should be more of a clinical judgment rather than a set figure. I think I'm done with this. I'm not going to offer any summary because I think this is not something which I can summarize in a slide. We can take up more questions on the aspect later on in the discussion. Thanks.
Yeah, thank you, Dr. Okay, Shefali, continue.
Yeah. Thank you, sir, for a very extensive and important discussion on this topic, which was really needed. So, questions we are going to take up at the end of the session, I think. And now I think I would invite Dr. Madhusudhan to discuss about the radiology of pancreatic cancer. So, Dr. Madhusudhan, kindly share your screen, please.
Yeah. Thank you, Dr. Shefali and Dr. Nikhil, for inviting me to this. Let me share my screen. Yeah, so I'll be focusing on the radiological evaluation of pancreatic cancer. So the main role of imaging is in the detection of a lesion, then characterization of the lesion, whether it is CA or something else, then in staging once the CA has been diagnosed, and then in any further management as well. And these are the list of investigations which are available, most commonly used: ultrasonography, CT scan, and MR. Of these, CT scan is the one which is most widely used and is the workhorse in the evaluation of patients who have adenocarcinoma of the pancreas. Let's start with ultrasonography. It is the initial screening modality. Any patient who presents with obstructive jaundice will get an ultrasound first, and ultrasound is the modality which determines the level of obstruction and also often the cause of obstruction as well. So it can help in determining the size, contour, texture, echogenicity of the pancreas, any abnormality within the pancreas. It helps to identify any mass within the pancreas, whether it is in the head or body. Often tail is not easily visualized on ultrasound, but if it is a large mass, may be seen. Then in addition, there may be dilated pancreatic duct, intrahepatic biliary radicals, and any lesions in the liver. And uncommonly, you'll be able to see the involvement of the vascular structure, especially the venous structures. Arterial structures may be difficult to evaluate, but venous structures is possible. Any involvement of these structures can be identified on an ultrasound. These are some of the cases. So often many of the patients present with a decent sized mass. This is one such case where you have a mass in the region of the head of the pancreas, and this is the pancreatic duct which is dilated up to the level of the mass, and then there is cutoff of the duct. And then if you put in a Doppler, you can see the vascular structures. This is the celiac hepatic artery, common hepatic artery, which is very close to the mass itself. And this is the portal vein. So we are able to see the vascular structures, although it is not very accurate in defining the involvement of the vascular structures. But if any artery or any vessel which is coursing through the mass, then it can be fairly sure that it is involved by the mass. And there's another case where you can see a large mass in the head of the pancreas, and this is the pancreatic duct which is dilated and it is cut off by the mass itself. Then this is a mass in the region of the tail of the pancreas. So it's not as clear as what you see in the region of the head, but still, if it is a fairly large mass, then ultrasound can help in detection of these masses. Then further additional findings which you can see on an ultrasound is the biliary dilatation. Most of the head masses cause biliary obstruction, and then there will be dilatation of the intrahepatic biliary radicals. And in case of metastatic disease, you'll be able to see the characteristic targets shape, the target appearing lesions within the liver. So this definitely suggests a metastatic disease, and just sampling of these lesions would be enough to confirm the diagnosis. Then there are some additional benefits of ultrasound. One is sampling. although US guided sampling is the one which is preferred in patients with CA pancreas, but in patients who are inoperable, then in those patients a transabdominal ultrasound guided sampling is can be done. You can just put in a needle through the abdominal wall under ultrasound guidance, and sampling is done. And then another important role of ultrasound is in intraoperative setting. So this is one of the important situation because the vascular involvement is very well demonstrated on an intraoperative ultrasound. As you can see here, because the probe is directly placed over the pancreas, the vascular structures are very well visualized. This is the SME and this is the SME, and we can see a clear fat plate between the mass and the vascular structures. So vascular involvement can be better evaluated with US and with intraoperative ultrasound. Then coming to the CT scan, which is the main investigation which is done in patients with obstructive jaundice. So typical protocol is the pancreatic protocol, which involves a pancreatic phase and a portal venous phase. So pancreatic phase typically is performed at 40 seconds because this is the phase at which the entire pancreas enhances maximum. So you can see that the entire pancreas is homogeneously enhancing, and since most of the adenocarcinoma are hypovascular, they can easily be seen within the enhancing pancreas. So identification of a lesion is easier when you do a pancreatic phase. And then in addition, this pancreatic phase itself, you can see the arteries are very well opacified, and you can see any vascular involvement, vascular variations, arterial variations can be identified on this phase itself. Then it is the portal venous phase, which helps in identification of the local staging, that is the venous structures, as well as any presence of any lymph nodes and any liver lesions as well. So these are some of the cases. You can see here there is a mass in the region of the head of the pancreas. As I said, this is hypodense compared to the rest of the parenchyma here, and in this case it is involving the supramesenteric vein. So this is the vein and this is the artery here, and these are the coronal sections of the same where it is involving the supramesenteric vein and portosplenic confluence. This is a mass lesion, which is a hypodense mass lesion in the region of the body of the pancreas. And then further, when you do multi-phase imaging, you can see vascular involvement is very well visualized. You can see this is the celiac trunk, this is the splenic artery, and this is the common hepatic artery. So the mass is right at the bifurcation of the celiac trunk and involving this. Then in addition, so you need to identify the tributaries of the vein and branches of the supramesenteric artery as well, if they are involved or not. In this case, you can see this is the gastrocolic trunk, and this is the mass lesion in the head of the pancreas. So you can see that the mass is abutting the gastrocolic trunk and the supramesenteric vein. So one important differential for masses in the pancreas are the neuroendocrine tumors, as you can see here. So the enhancement of this lesion, neuroendocrine tumors, are different compared to the adenocarcinoma, so which should be kept in a differential. You can see that adenocarcinomas are hypodense, whereas neuroendocrine tumors are hyperdense. Okay, and you can see liver metastasis as well within this case. MRI is uncommonly done for the evaluation of adenocarcinoma of the pancreas, but having said that, there are situations where MR is done when the lesion is not clear on a CT scan, because up to 10% of the cases may be isodense, and the detection may not be possible on a CT scan itself. So in those situations, MR can be done. But sometimes, because the patient presents with obstructive jaundice, a few clinicians suggest an MR on the first go, and then MR is done in that setting. So again, MR, we have the typical sequence and standard sequences. This is a T2 weighted sequence, this is a T1 weighted sequence. Then you have a diffusion weighted sequence, which helps in differentiating usually between a benign mass and an inflammatory mass from a carcinoma. And then you do that standard phase, the arterial phase, the pancreatic phase, and the portal venous phase. So these are some of the cases. This is a T2 weighted image. You can see a large mass in the region of the head of the pancreas. And this is the characteristic double duct sign on an MRCP image. You can see the bile duct, which is dilated up to the level of the head of the pancreas. And then this is the pancreatic duct, which is also dilated up to the level of the head of the pancreas. And there is a cutoff at the level. And then this is the location of the mass. And then this is another case. The mass is seen as bright on T2 weighted images, and then this is the T1 weighted images where the mass is hypodense, and this is the diffusion weighted image showing that there is restriction of diffusion. And as I said, there is the mass usually appears hypodense or hypointense because it is hypovascular compared to the rest of the parenchyma. And this is the MRCP, which shows the dilatation of the pancreatic duct. Thus, MR also helps in characterization of the lesion, and this is the typical appearance of a malignant lesion, that is adenocarcinoma of the pancreas. Now, once you identify a lesion, what are the features which you should look for in a patient who comes with a suspicion of adenocarcinoma of the pancreas? One, as I said, is to identify the presence of a mass, whether it is ultrasound or the CT scan. You are able to identify a mass based on the enlarged, there is contour abnormality, as in this case there is a large mass itself, or in this case there is contour abnormality and then there is hypoenhancing lesion. Or again, here there is contour abnormality. This is the tail of the pancreas, which is atrophic, and then suddenly there is a large mass here. And then there is an MR T2-weighted image, which shows a large mass here in the body of the pancreas, and then there is atrophy of the tail. So presence of mass itself is easy to identify. But in some cases, when the mass does not cause any contour bulge or it's within the pancreatic parenchyma itself, then we should use the enhancement pattern as a marker of identification. As I said, the pancreatic mass, pancreatic adenocarcinoma is hypovascular. So you can see here there is a hypovascular mass. It's only causing mild contour bulge here, and this is the pancreatic parenchyma. There is not much atrophy. And then most of the hypovascular masses are usually adenocarcinomas, and this is the MR of a different patient where you can see a hypovascular intense mass in the region of the head of the pancreas, and in addition this patient had multiple metastases. Compared to this, neuroendocrine tumors are very hypervascular. You can see here there is a enhancing mass. This is the normal parenchyma anteriorly, and then deeper to that you can see an enhancing mass. Similarly, on an MR, you can see an enhancing mass here. So any lesion which is hyper-enhancing compared to the rest of the parenchyma is usually a neuroendocrine tumor, and they usually do not cause any mass effect, unlike ductal adenocarcinomas, which cause dilatation of the pancreatic duct as well as dilatation of the CBD. Then coming to the internal architecture, most of the times the lesions are solid, but 5 to 10% of the adenocarcinomas can be cystic. Like in this case, you can see only peripheral thick rim enhancement and center part is completely necrotic or cystic. So this is one of the uncommon appearances of adenocarcinoma. But more commonly, cystic lesions are either serous cystadenomas or mucinous cystadenomas or solid papillary epithelial neoplasm. So these have different appearances on imaging, and so whenever you see a cystic lesion, so these differentials are more commonly seen than a cystic pancreatic ductal adenocarcinoma. Then you should look for secondary signs. As I mentioned, double duct sign is the most common feature which can be seen in patients with adenocarcinoma of the head of the pancreas. And then you can generate curved MPRs on the CT itself to show the entire length of the pancreatic duct leading up to the mass. So the characteristic duct cutoff is the feature which is used to differentiate any benign masses in the head of the pancreas compared to a malignant mass. In a malignant mass, because the mass arises within the duct itself, it causes complete cutoff of the duct, whereas in case of benign masses or inflammatory masses, the duct is usually seen, although thin, but it's usually seen going through the mass itself. Okay. And then any presence of vascular abnormality. This helps in identification of the, in staging the disease. As in this case, you can see this is the supramesenteric vein and this is the first jejunal vein. Both of them are abutted by the hypodense mass lesion here. And then here in this case, the splenic artery up to the celiac, origin from the celiac trunk, is encased by the mass itself. So presence of this vascular abnormality in case of an isodense lesion, if the enhancement pattern is similar to that of the normal parenchyma itself, then presence of any vascular abnormality can suggest that there is probably a mass there. So this local invasion, that is vascular invasion, is one of the important point which helps to define whether the lesion is resectable or not. So the terminology which is commonly used is abutment and encasement. Abutment is when the angle of contact between the vessel and the tumor is less than 180 degree. As in this case, you can see here, so this is less than 180 degree from here to this point. Whereas if it is more than 180 degree, then it is called encasement, because it is suggested that if the angle of contact is more than 180 degree, then there are high chances that the tumor will be unresectable. So what are the important things which you need to look for? That is presence of fat planes, any contour abnormality of the vessel, look for the caliber of the vessel, So as in this case, you can see this is an MR. So there is a hypointense mass lesion in the head of the pancreas, and although it is very close to the SMV, you can see that there is still a black line seen, a fat plane seen between this mass and the superior mesenteric vein. Although the first branch is abutted by the lesion. So in this case, again, you can see that it is just abutment, it is just touching, but the angle of contact with the SMV is less than 180 degrees. So it is just abutting the SMV. Whereas in this case, it is very close to 180 degrees. So it's probably encasement. This is a superior mesenteric artery, which is encased by the mass. Here, again, you can see that there is contour irregularity. There is encasement as well. And you can see the outline of the hepatic artery and the splenic artery very irregular. So any contour irregularity suggests that there is vascular involvement. So in this case, in addition to more than 180-degree involvement, the caliber is also smaller. So this is the superior mesenteric artery. Typically, superior mesenteric vein should be larger in caliber than the superior mesenteric artery. So in this case, there is narrowing of the superior mesenteric vein. As in this case, again here, you can see narrowing of the superior mesenteric vein. So any vascular involvement will make surgery difficult, and the arterial involvement usually makes it unresectable, whereas venous involvement, it can be still a borderline resectable tumor. Metastasis can be nodal metastasis, as in this case, you can see a paracaval, aortocaval, or para-aortic group of lymph nodes which are enlarged, which are usually away from the draining area. Then you can have multiple liver metastasis, or you can have mental metastasis as well, peritoneal metastasis. So this definitely defines the patient as inoperable, and patient has to go for a palliative setting. So staging, as I said, local organ invasion is important, but most important is the vascular involvement. Should look for involvement of the superior mesenteric artery, the celiac artery, hepatic artery, and then venous involvement is SMV, portal vein, and IVC whenever it is close to the IVC. And then lymph node involvement is retroperitoneal involvement, makes it usually unresectable because it suggests metastatic disease. And then distant organ involvement, commonly the spread is to liver and the peritoneum. So this is the guidelines by NCCN for surgery. You all surgeons would know it better. But on imaging, if there are no metastasis and no lymph node involvement, they would suggest that the tumor is resectable. And presence of metastasis and lymphadenopathy and involvement of the artery, SMA, celiac artery, and proximal common hepatic artery would make it unresectable. So it's only this stage when there are small lymph nodes or tiny lesions or no metastatic lesions in the liver and venous involvement. So makes it borderline resectable because you can still resect the venous segment and then do an anastomosis. And some tumors which are just abutting the SMA with less than 180-degree contact may still be resected. So in conclusion, I would say that ultrasound is the initial screening modality, and often it helps to decide what is the next investigation which needs to be done. If it is already metastatic, then imaging may not be needed and just simple sampling should be sufficient. CT scan is the modality of choice, and it is typically the pancreatic protocol in dual phase which is done. MRI is done in difficult cases, and often it helps in problem solving. Thank you for your kind attention.
Yeah, Dr. Nikhil, are you there? So to continue.
Yeah, thank you, Dr. Madhusudhan. That was a very informative presentation. We are way running behind time. So Dr. Vikas Singla, yeah, I can see him. So please tell us about the role of endoscopic ultrasound in pancreatic cancer. Dr. Vikas Singla is authority in endoscopic ultrasound in India. And I've seen him doing endoscopic ultrasound, and he actually does a wonderful job at that. So let's welcome Dr. Vikas Singla.
Yeah, good evening to all of you. Thank you, Nikhil, for the very kind words, and thanks, Dr. Shifali, for the invitation. So first of all, we should know what is endoscopic ultrasound. So endoscopic ultrasound, it combines the endoscopy with the ultrasound. It combines the property of endoscopy with the ultrasound so that we can do a ultrasound with the help of endoscope. So there are two types of echo endoscopes, radial and linear. With the radial, there is a transducer at the tip, and we get a 360-degree view. And in the linear, we get a 110 to 130 degree view. And with the linear, we can take FNAC also. With the radial, we can't take FNAC. If we have to take FNAC, we have to use the linear scope. So with endoscopy, we can see just the mucosa. We cannot see beyond the mucosal layer. And with the endoscopic ultrasound, we can see the structure which are surrounding the esophagus, stomach, duodenum, or rectum. So with the endoscopic ultrasound, we can see the structures which are abutting the esophagus, duodenum, stomach, and rectum. So for pancreatic evaluation, we can evaluate pancreas from the either from the stomach. We can see that pancreatic body and tail is in close contact with the stomach. So from the stomach, we can see pancreatic body and tail. And from D1, we can see pancreatic head. And this is area of uncinate, which we can see from the second part of duodenum. So this cartoon shows all the structures which we can see with the endoscopic ultrasound. This is the left side of patient and this is the right side of patient. We can see the aorta, IVC. We can see both the kidneys and the adrenals. This is the portal vein, SMV, celiac, SMA. This is the bile duct, pancreatic duct. And this is the pancreas and the spleen. And anterior to this structure is the stomach and duodenum. So with the help of echo endoscopy, we can see all the structures from the stomach and the duodenum. And for evaluation of pancreas, first we go into the stomach. This is the patient lying in the left lateral position. So first we go in, we take our echo endoscope to the mid gastric body, and then we take a clockwise torque. So from the stomach, we can study the SMV portal vein, we can study the SMA celiac axis, and we can see pancreatic body and the pancreatic tail, and we can see the gallbladder and the bile duct. So we can see the any mass lesion which is in the pancreatic head or the pancreatic neck, pancreatic body and tail. And we can define the resectability with regard to SMA, celiac, portal vein, and the SMV. And this is the echo endoscopy image. This is the pancreatic neck, and this is the confluence of SMV and the splenic vein, and this is the portal vein. So we can see that we get a very good resolution of pancreatic body, and we can see the veins very well. And then we can see the SMA. This is the SMA and the celiac axis. So we can see arteries are slightly away from the vein. Veins are closer to the probe. That's why it gives better resolution. And in terms of resectability, it gives better idea about the veins than the arteries. So this is from the stomach. We are seeing the vessels, SMA, SMV, celiac, and the pancreatic body and tail. Then we go to the first part of duodenum. So here there are two scope positions. One is a facing up. When the scope is facing up, we can see the CBD and the liver hilum and the gallbladder. And when the probe is facing down, this is facing up. And when the probe is facing down, we can see the pancreatic head. So D1 is the best station for evaluation of pancreatic head. And we can see this is the portal vein, and below is the SMV. This is the again confluence. So this is the splenic vein. This is the SMV. This is the portal vein, and here we can see the pancreatic parenchyma. So D1 is the best station to evaluate the pancreatic head, and most of the pancreatic adenocarcinoma, they arise from the pancreatic head. And we can again define the resectability with regard to portal vein and the SMV. And then the station is the D2. We go in the second part of duodenum. From here we can see the ampulla. So sometimes there is a very small tumor at ampulla. For that we go to the second part of duodenum, and this is uncinate between aorta and the SMA. And from the second part of duodenum, we can see tumor which are very close to the ampulla, ampullary malignancies, and we can see the uncinate process. So these are the structures which we can see from the second part of duodenum. This is the aorta we see from the second part of duodenum. And then we can see the this is the common bile duct. We can see that this is the terminal part of common bile duct, and this is the distal part of pancreatic duct. So if there is any small tumor at the ampulla, it can be seen from the second part of duodenum. Conventional imaging can miss the small tumor in this area, which are very small, and this can be picked up by the endoscopic ultrasound. Now coming to the role of endoscopic ultrasound in pancreatic cancer. So we can do the conventional EUS, with which we can see the mass lesion in the pancreas. Then to improve the specificity, we can use the contrast enhanced EUS and the EUS elastography, especially in patient with the chronic pancreatitis, where the specificity of EUS is low. So in this setting, the contrast enhanced EUS and the EUS elastography can improve the specificity of the EUS. And then if desired, we can take the fine needle aspiration of the pancreatic mass lesion also. So what is the role of EUS? First is the detection of lesion. So whenever there is patient of suspected pancreatic malignancy, we want to see the lesion. So EUS can pick up the lesion. Then we have to define the resectability, and maybe we have to establish differential diagnosis. And if it's a unresectable malignancy with the severe pain, we can do the celiac plexus neurolysis for the pain relief. And for the biliary drainage, ERCP is ideal, but sometimes because of duodenal obstruction, we cannot reach the papilla. In that case, we can do EUS guided biliary drainage. Now coming first to the detection of a lesion. So whenever there is a suspicion of malignancy, like in elderly patient with the biliary obstruction, we should rule out the malignancy. So CT is the most commonly used modality. So if we compare CT and the endoscopic ultrasound, EUS has better sensitivity than the CT scan. You can see here sensitivity of EUS is the more than 95%, and the CT sensitivity is between 70 to 80%. But with the improvement in the CT quality, this difference is likely to get narrowed. And now I think the sensitivity with the latest machine is more than 90%. And though the sensitivity of EUS is higher than the CT scan, CT should always be the first modality. If you are thinking it's a malignant biliary obstruction, CT should be the first modality. There are reasons for it, because it has a wider availability. Patients are more comfortable doing a non-invasive investigation, and CT gives us a wider information. It gives more information regarding the distant metastasis also. So these are the various studies which has compared EUS with the CT scan. We can see across all the studies, EUS has shown better sensitivity than the CT scan, and overall sensitivity is 94 for the EUS and 74 for the CT scan. And yes, EUS is more sensitive for the smaller lesion. If the lesion size is more than 3 centimeter, EUS and CT are equal. On the other hand, if the lesion is less than 2 centimeter or 1 centimeter, EUS is better than the CT scan for detection of a lesion. So we should first do a CT scan. If CT is negative, it's not showing any mass lesion, EUS should be the next investigation. CT can miss the lesion. In a study of 86 patients, CT missed the lesion in 14 patients. And EUS could detect 12 more lesions as compared to CT scan. So when we combine CT and EUS both, only two lesions were missed. So CT should be first modality. CT is negative, one should do the endoscopic ultrasound. And for defining the resectability, CT and the EUS are complementary. EUS gives better idea about the portal vein and the SMV, and CT scan gives better idea about the SMA and the celiac axis. So they are complementary. So once we have done the CT scan, as Dr. Madhusudhan mentioned, the lesion will be classified as resectable, borderline resectable, and the unresectable. So next question is, should we do the USFNA in every patient with the pancreatic mass? The answer is no, because the USFNA, the yield is not very optimum. We can see the sensitivity of USFNA for detection of a lesion is 85%. If you're doing FNA, out of 100 malignant lesions, it will be positive in 85. So in 15% of the patient, USFNA may be false negative, and these patients will be denied surgery. The USFNA yield is increasing with the availability of better needles. Now it's approaching around 95%. And on the other hand, if we offer surgery, Whipple surgery, to every patient with the pancreatic mass lesion, it's well known that there will be 5 to 15% of surgery will be for the benign lesions, especially in patient with the chronic pancreatitis and patient who consume alcohol. So when should we perform FNA in a patient with the resectable lesion? These are the recommendations from the pancreatic surgery study group, which has suggested that FNA should not be done if it's a suspected malignant lesion. Like the patient is elderly, non-alcoholic, double duct sign, CT showing a mass lesion, resectable lesion, there is no indication of FNA. On the other hand, if autoimmune pancreatitis is suspected, that pancreas is diffusely bulky, sausage shaped, or MPD is not dilated, in that case, it can be autoimmune pancreatitis and FNA should be done. Similarly, in the patient with the chronic pancreatitis who has long-standing chronic pancreatitis, and there is a high suspicion of malignancy, high bilirubin, high CA19-9, in those patients, the sensitivity of EUS-FNA is again very low. So these patients can be directly taken up for the surgery, provided the risk of malignancy based on the conventional imaging is high. On the other hand, FNA should be done if the plan is for the neoadjuvant, especially in the case the lesion is borderline resectable. In this patient, we can downstage the tumor with the neoadjuvant. In this patient, the FNA should be done. Similarly, if there is a suspicion of autoimmune pancreatitis, we should take the FNAC. Similarly, if there is a suspicion of tuberculosis, especially in the endemic country like India, sometimes we have a young patient who had a pancreatic mass without MPD dilatation, and there are multiple necrotic nodes. This can be tuberculosis. Similarly, we have many patients with the lymphoma. Again, the clue will be large round nodes, especially around the vessels. Again, this can be lymphoma. So young patient with a suspicion of tuberculosis or lymphoma, one should always confirm a diagnosis by FNAC. And similarly, alcoholic patient, if patient is taking alcohol for a long time and coming with the pain and CT showing a mass lesion, we should always do FNA because it can be an inflammatory mass also. And neuroendocrine tumor also, we should try to establish a tissue diagnosis because the extent of surgery will be different in these patients. So as I mentioned, suspected biliary obstruction, suspected malignancy, one should go ahead with the CT scan. If CT is showing no mass lesion and or there is a suspicion of benign disease like tuberculosis, lymphoma, we should do the endoscopic ultrasound. On the other hand, if CT is showing the mass lesion and there is very high suspicion of malignancy, resectable lesion, upfront surgery can be done. Borderline resectable, there are two options depending on the center's protocol. One can either do the upfront surgery, or if the plan is neoadjuvant, one can do the EUS-FNA. Unresectable lesion, the best is to do ultrasound-guided FNAC. If window is not available, we can do the EUS-FNA. And if CT is non-confirmatory, we should do the endoscopic ultrasound. And now coming to the role of contrast enhanced EUS and the elastography. So in patient with the chronic pancreatitis, once we see the mass lesion, the specificity of the EUS alone is low. And even after the addition of EUS-FNA, the specificity of the EUS will be low. In this patient, we can do the contrast enhanced EUS or the elastography. For contrast enhanced EUS, we inject a solution containing the gas-filled microbubbles, which are coated with the phospholipids, and they act as a reflector for the ultrasound waves. The malignant lesions, pancreatic adenocarcinoma, in the setting of chronic pancreatitis, they will appear hypovascular, and this will increase the specificity of EUS. And similarly, in the elastography, we see the compression of lesion after application of a force, and malignant lesions, they appear hard on EUS elastography. Again, it will increase the specificity of EUS. So both contrast enhanced EUS and the elastography may help in the patient with chronic pancreatitis with the mass lesion. This is how a mass lesion appear on the EUS. We can see, and this is the pancreatic head, and this is the lesion in the pancreatic head, and this is the portal vein. So we can see the mass lesion, we can define the resectability, and we can obtain the FNAC also. And FNAC should be done from the transduodenal route because duodenum will be removed during the surgery. So there is no risk for the needle tract seedling. And this is how a lesion appear on the, how adenocarcinoma appear on the contrast enhanced EUS. We can see that after the contrast application, there is no enhancement in the pancreatic mass. So this is adenocarcinoma. And this is the elastography. The blue structure is hard and the red is the soft. And we can see there is a stent inside the CBD. And around the CBD, we can see a hypoechoic mass lesion. And when we do the elastography, we can see that mass lesion is the bluish in color. So this is likely to be a adenocarcinoma. And this is an example from an alcoholic patient and who had pain for the 2 years, and he had persistent pain. CT revealed cystic lesion, likely walled off necrosis or pseudocyst. In addition, there was a mass in the pancreatic head. And when we took the FNAC, it was a adenocarcinoma. This was an alcoholic patient with a pseudocyst and pancreatic head mass, and this was a adenocarcinoma. And one more indication of EUS in pancreatic cancer is the EUS guided biliary drainage. As I mentioned, the ERCP is the ideal procedure for the EUS for the biliary drainage in patient with the lower end CBD block. And sometimes there is a duodenal obstruction due to pancreatic mass, and we are not able to reach the papilla. In these patients, we can do EUS guided choledocho duodenostomy. We can create a fistula between the CBD and the first part of duodenum. We take our scope to the first part of duodenum, then we puncture the CBD from the first part of duodenum, and then we pass a wire, we dilate the tract, and we deploy a stent between the first part of duodenum and the CBD. So we have created a fistula between the CBD and the first part of duodenum, and CBD is very close to the first part of duodenum, and so there is no risk of bile leakage. And this was a patient with the CA pancreas, and this is the first part of duodenum. From the duodenum, we can see this is the dilated proximal CBD, and this was the pancreatic mass lesion. We can see there mass is obstructing the CBD. So we puncture the CBD with the 19G needle, and then we dilate the tract with the cystotome. This is a cystotome. With that, there is a ring, diathermy ring at the tip. With that, we can do the cautery and dilate the tract, and then we can place a stent over the to the tract, and it should be a covered stent, covered metallic stent. We can see that we are deploying a stent between the duodenum and the first part of duodenum and the CBD. This is choledocho duodenostomy, and choledocho duodenostomy is a safe procedure, and we published data of 12 patients, and we could achieve the success in 11 patients, and there is low risk of stent migration, as these are the covered stents. There are 2 stent patient had a stent migration, and this was replaced by a plastic stent because after 6 months there was a fistula formation. So even putting a plastic stent was sufficient. Another indication is a EUS guided gastrojejunostomy. Sometimes patient with the CA pancreas and unresectable lesion, they can have a gastric outlet obstruction. In these patients, conventionally we put a duodenal SEMS, and that mostly is a uncovered stent, and there is a risk of tumor ingrowth in the uncovered stent. So in these patients, now the upcoming treatment is the gastrojejunostomy. So this is a creation of a fistula between the stomach and the jejunum. So here we can see that our probe is in the first part of probe is in the stomach, and we have placed a nasoduodenal tube. So first we do endoscopy. We place a nasojejunal tube, and then we inject the fluid through the nasojejunal tube, and we distend the jejunum. And this fluid is stained with the methylene blue. And from the stomach, now we can see there is distended jejunal loops. Then we can puncture the loop, and through that we can place a 20 mm covered stent. So this is EUS guided gastrojejunostomy, and there is no risk of tumor ingrowth because there is no tumor in the vicinity of GJ site. The tumor is in the D1. So the stent patency should be higher with the GJ. And CPN we do for the patient who had unresectable lesion and with the severe pain. In this patient, we can inject absolute alcohol in the celiac ganglion or in the celiac plexus. The efficacy for the pain relief is more than 90% in these patients. And EUS has a, I think, very limited role in the ampullary tumor because with the side-viewing endoscopy, we can see the tumor directly. It's rare to have an ampullary tumor with the normal side-viewing examination. In case the overlying mucosa is normal, with the endoscopic ultrasound, we can see a small tumor in the ampullary region, and even we can take a FNAC also. But EUS has a limited role in patients with the ampullary tumor. Now coming to the cholangiocarcinoma, cholangiocarcinoma can arise either from the intrahepatic CBD or they can arise from the distal CBD. ERCP has a limited sensitivity for evaluation of cholangiocarcinoma. Sensitivity is between 20 to 60%. If we need a tissue diagnosis, EUS-FNA has a higher sensitivity for evaluation of a tissue diagnosis for cholangiocarcinoma. In a study of 81 patients, we can see that EUS can detect more tumor as compared to CT scan. And FNA positivity for EUS FNA is 73%. It's higher for the distal as compared to proximal cholangiocarcinoma. And in distal cholangiocarcinoma, we can obtain transduodenal FNAC from the lesion, and this tract will be removed. So again, there is no risk of tumor tract seedling. This is a patient with the distal cholangio, and we can see a metal stent in situ, and we can see a hypoechoic thickening around the stent. And this is the needle. We can see that we can take a FNAC from the thickened area if required. And here we can see again a tumor which is aborting. There is a plastic stent in situ, and we can see it's a cholangiocarcinoma, and we can define the resectability, and we can see there is loss of interface between the portal vein and the tumor. And this was an interesting case. Again, suspected a young female, suspected distal cholangiocarcinoma. We can see there is a mass lesion around the CBD, and when we took the FNAC, it was showing the necrotic granuloma, AFB positive. So we placed the stent inside the CBD and started the chemotherapy, and within the 6 months, this lesion disappeared. Sometimes we have patient with the distal cholangiocarcinoma or benign stricture, and sometimes this can be PSC, and echoendoscopy of liver can help in these patients. We could see that there are multiple areas of dilatation.
I think Dr. Vikas is having some network issues. He's trying.
Yeah.
We have to just wait for 1 minute. Yeah.
Dr. Shefali, I think we can take up the next speaker.
Sure. Dr. Vikas is calling up. Just I have to take call. Just 1 second. Hello. So I think Dr. Vikas may not be able to join, having network issues. So we move on to the next speaker. I would like to invite Dr. Gurudat, sir. He's a head of histopathology in Rajiv Gandhi Cancer Institute, and he'll be discussing on surgical pathology. So welcome, sir, for your talk.
Thank you, Dr. Shefali. I'll try to. Share screen.
On the top corner, sir, there will be.
Yeah.
Right, sir.
Screen visible?
Yes, sir, it is visible.
Okay.
Yeah. So please make it a full view, sir.
Yeah.
Yes, sir.
Good evening, everyone. I thank Dr. Shefali and Dr. Nikhil for the invitation. My topic is surgical pathology of pancreatic cancer. So it is a common tumor, third most common cause of death. 5 years trial is still dismal. And with advanced imaging, we have already seen small lesions can be detected as told by Dr. Singla. Unfortunate thing is there is no targeted therapy for pancreatic cancer. Still, it is chemotherapy-based treatment. Only approved therapy is checkpoint inhibitor, pembrolizumab, and surgery is the only definitive treatment. And most masses are primary to pancreas with very few metastatic diseases. Now, really metastatic disease can be seen, and tumors from surrounding structure may resemble radiological, the pancreatic mass. And periampullary region is a complex region which is composed of distinct anatomical structure, the head of pancreas, distal CBD, second part of duodenum, and ampulla of Vater. So these are included with periampullary carcinomas. And this is the most common malignancy for patients to receive pancreatic duodenectomy, that is the section of the pancreatic head with the duodenum. That is the Whipple surgery. And ampullary tumors, they constitute only 6 to 9% of the this periampullary tumors, and survival is also best for them, around 45%. And there is some merit in stratifying them into the intestinal and pancreatico-biliary, and this has some prognostic significance, where intestinal have better prognosis and pancreatico-biliary do not have, they have worse prognosis. And this is a new WHO 2019 edition that MUC5AC expression is a bad prognosis sign, which is actually a gastric differentiation. Coming to location, I think this is not needed. Anything in the left border, right of the left border of superior mesenteric vein is head of pancreas, then it is the body and the tail. Now, head is the most common site, we all know. Body only 11%, tail only 11% for the pancreatic carcinomas. Now, coming to ampullary tumors, this is a new addition, which is given in 2019 WHO. So most duodenal cancers, they arises from ampullary region, and those arising deep within the ampulla, that is this region, they are called ampullary ductal origin, and they differ from cancers originating from duodenal surface, that is periampullary duodenal, this area. And the difference is 29% and 52% 5-year survival. And this is because this papillary intraduodenal origin, they have more intestinal differentiation. And other upper small intestine carcinoma sometimes exhibit gastric differentiation, which we have seen MUC5AC. So this has been incorporated in WHO. So there are 4 types: IAPN associated, that is intra-empillary papillary neoplasm. You can see the papillary neoplasm and infiltrating into the ampulla. So this is IAPN associated. Then ampullary ductal, where there is no papillary component infiltrating, and ampullary duodenal, which arises in ampulla and involves and the duodenum. And when they arise from the papillae of ampulla of Vater, they are called ampullary NOS. So WHO classification, it is almost same as 2010. They have only added invasive micropapillary carcinoma in these. Now, when we do cytopathology, we cannot have so many differentials. So usually it is ductal adenocarcinoma, mucinous, and acinar, pancreaticoblastoma, and endocrine and SPAN. So how to approach a pancreatic mass? For a pathologist, you should know whether it is solid or cystic, what is the location, head, body, tail, whether it is multiple, single, what are serum markers. Sir has already told us in detail about CA 19.9 and CEA. So that correlation is very important. Involvement of adjacent organs and lymph nodes, and in case of cystic masses, fluid analysis may also help. So solid will be ductal adenocarcinoma, acinar cell, pancreaticoblastoma, endocrine neoplasms. Then cystic with true cyst, serous cystadenoma, mucinous cystic neoplasms. cystic intraductal will be IPMN, and degenerative, any tumor can be degenerative and can lead to cystic change. And this outlines the cellular differentiation and the ISC we use. For example, for ductal, it will produce mucin, CK19, CA19.9, CA, and MUC1. Acina, they are enzyme production, that is trypsin, chymotrypsin, and lipase. And acina, which includes acina cell carcinoma, pancreaticoblastomas. And endocrine, they produce peptide hormone, and we use chromogranin, cyanotrophysin. And you can use specific markers like glucagon, insulin that are not required, but they can be used if you want to characterize. This has been covered by the surgeon, so I will skip this. Now coming to cytopathology. Now breast cytology is no longer done. We don't do it. So aspirations are usually done for unresectable tumors, and usually our endoscopists, they do rapid on-site screening, so it permits the additional pass and improve the adequacy. So rapid on-site screening is important. We do it with field stain, and it is done for all the procedures US guided, and we have a trolley especially made for that, and it reduces the inadequacy rate. We have only 5 to 6% inadequacy rate in RGCI. Now, what is the role of cytopathology? It can differentiate benign or malignant lesions when adequate. Whether adenocarcinoma is ductal or mucinous, it can identify epithelioid morphology, that is, solid pseudopapillary neoplasm can be suspected, neuroendocrine carcinoma can be characterized, acina cell carcinoma can be diagnosed. And it can also identify the signet ring anaplastic feature, osteoclast-like giant cell, which portends the poor prognosis. It can diagnose non-epithelial tumors like mesenchymal tumors or metastasis. So sample collection we have already covered, so I'll skip it. But best part is the EUS guided is it is cost effective and it avoids surgery and expedite the therapy, especially chemotherapy. Now coming to limitation of EUS FNA. Now limitation is that visible lesions are only sampled. Cystic neoplasms, it has low sensitivity because the cellular yield becomes less. And it is highly dependent on the experience of endosonographer. So we depend on the experience and the feedback they give. That helps in the diagnosis because sometimes material can be very scant. The number of needle passes, more passes, better material. Second common issue is contamination from GI lining tissue because the needle is passed through the duodenum or from the stomach. So they will be contaminating cells. So they should be identified by the pathologist and should not diagnose them as malignant. And especially when the lymph nodes are targeted, the overlying primary tumor may contaminate. So that has to be kept in mind. So three categories are straightforward: inadequate, benign, and malignant. However, sometimes the diagnosis can be atypical or suspicious. This also helps in guiding the treatment and subsequent management of the patient. Now coming to limitation of biopsy. Now what we get is FNAB. Nowadays FNAB is commonly done, or cell blocks, which are thin cores, which are fixed in formalin in our case. Some people also fix in alcohol, that is not recommended. Architecture, however, is compromised because cores are very thin. Their material is scanned, and so the pathologist should build the habit of scanning whole section, look for clues for any lesion, and compare with normal histology because some cores may contain the normal pancreatic tissues, so that you know that biopsy is done from the pancreas. And scanned material, especially when you get the serous, fibrous, inflamed tissue, should look for autoimmune pancreatitis, that is IgG4 disease, and secondary involvement and non-epithelial neoplasms. So this is just to compare the size. This is a lung biopsy, USG guided, and this is the US guided pancreatic biopsy. You can see the difference between the size of the core, that is the thickness is very contrasting. Now this also shows the same thing. This is the breast biopsy, this is prostate biopsy, this is mesenteric omental biopsy, this is a cell block from pancreas, this is the pancreatic biopsy. So you can see the very thin cores, and I measured them, they are only 0.4 mm thick. So this is the serous stroma, and some areas you can see the tumor. So that is why the tissue always will be scanned. And in this case, it was a metastatic from the lung. So one case, mucinous lesion in a 51-year-old male, and clinically it was suspicious of mucinous lesion. And on aspirate, we could see the mucinous cell in the background of mucin. And this is a cell block which is showing the mucin lined tissue core. So mucinous neoplasm was suggested, which was followed by the total pancreatectomy. And you can see the IPMN with low-grade dysplasia, main duct. And MUC5AC was positive, MUC1, MUC2 were negative. So it was gastric type. Now coming to resection type specimen, which is the main part of my talk. Now surgical anatomy, we have already seen retroperitoneal organ and resected along the segment of duodenum, that is the Whipple's procedure, and it is closely associated with veins and arteries. So these are the anterior relations, liver, stomach, the mesocolon, then colon, the transverse colon. This is the posterior relations, the portal vein, the aorta, vena cava, left kidney, and the spleen. This is from Chaurasia, that how to stimulate the anatomy of pancreas. This can be used. So this is an article which was published in 2006 by Verbeek and co-workers. So they have defined a standardized protocol for pancreaticoduodenectomy specimen by using multicolor margin staining and axial slicing. That we'll see what is axial slicing. So they their R1 rate got increased to 85%. So this was their main finding. So they advocated the axial sectioning of pancreaticoduodenectomy specimen. And this is using the multicolor. This is the pancreatic yellow, pancreatic neck margin. Blue is the SMV and orange is the SMA. So this is the vascular surface, which is they have marked, and they have included the uncinate margin with the SMA. So this is how you start from the superior, go towards the inferior, give axial cuts, and then you can see the tumor and the SMA margin and the margins and SME margin, and you can measure and study it. And then later they published after 2 years impact of margin status, and they showed that R1 rate was high in pancreatic, that is 82%, bile duct 72%, and for ampullary it was 25%. So it was very high R1 rate for pancreatic tumors. So, and later in this Scandinavian study, they showed that a margin of at least greater than 1 mm leads to better survival in pancreatic ductal adenocarcinoma. So compared to less than 1 mm. Now, this paper was published in 2014 by Volkan and colleagues. So they actually disputed this Leeds protocol of cutting the pancreatic duodenectomy specimens. They advocated a different approach. This we can see the pancreas from back, and here this is the pancreatic neck, this is the uncinate, and this forms the vascular groove. So this is actually the surface which is smooth. The uncinate is the rough surface, and this pancreatic neck margin is a rough surface. So these are the surgical margins, and this they said were the surface. So this one specimen we got on Monday, so I have taken a photograph. This is the uncinate, this is the vascular groove, and this is the pancreatic neck. So they advocated that you take a shave margin of the uncinate, ink it and take a shave margin, then just bread loaf it and embed it. And they compared the reporting recommendation of other agencies like AJCC, College of American Pathologists, Royal College of Pathologists, and similar to them, Royal College. Now we can see the CVD margin, the pancreatic neck margin, the uncinate margin are considered margin by all. Now, vascular bed margin, that is vascular groove, also called superior mesenteric portal bed margin, is taken as surface by them, whereas by Verbeck and Royal College of Pathologists, it is a margin. So that was the difference. And similarly, the anterior free surface is considered as a surface only, whereas it is considered as a margin by the Verbeck study. Similarly, the posterior free margin is also considered as a margin by them, but it is recommended to be a surface. So this is a controversy, but as we can see here, this is the vascular bed which is smooth, and this is the pancreatic neck margin, and this is the uncinate margin. Similar, same thing. This is the CBD margin, which is the transected margin. The probe through CBD into the ampulla. This is a tumor seen in the head of the pancreas. It was HOP carcinoma, and this is after the fixation. You can see it much more clearly. So what we follow is the CAP protocol, which I will show you later, to give our margins rather than Leeds protocol or one given by Volkan. Now this is showing a ampullary carcinoma. Here is a ampullary carcinoma. So mostly this is a ampullary duodenal type. Similar here, you can see it is centered in duodenum and ampulla obvator and going into the ampulla. So coming to the CAP protocol 2020 for head of the pancreas. Now non-peritonealized surface of uncinate process, the uncinate margin, constitutes the inferior posterior retroperitoneal margin of pancreatic duodenectomy specimen. So this area of the uncinate, which is dissected by the surgeon, is actually the retroperitoneal margin. So this should be inked and submitted. And section to the tumor at its closest approach to this margin should be submitted. Now, they advocate that we should ink it and the closest approach should be submitted rather than cutting it and bread loafing it. So this we usually follow. Then tumor of pancreatic bed corresponding to the uncinate margin and vascular groove. Inking of vascular groove corresponding to portal and superior mesenteric vein and submission of sections through tumor at its closest approach to this surface is recommended. Now they recommend that we give the closest margin from this vascular bed rather than giving axial sections, then giving multiples multiple margins from the vascular bed. And reporting of tumor involvement of anterior non-uncinate posterior surface is recommended, but it is not required. So they call them surfaces and not as a margin. So if you have tumor close to these surfaces, then you should give the surface, ink it and give it, but that is actually not a margin. It is a surface. The vascular groove, anterior surface, and non-uncinate posterior surface are not considered as recession margins. So that is again stressed. Now for intraductal carcinomas, the pancreatic neck parenchymal recession margin is very important, and common bile duct margin, the Whipple recession, are very important. So complete and phase section through pancreatic recession margin and CVD should be taken. And presence of tumor at or within 1 mm of recession margin constitute for all 1 mm recession margin is required. If it is less than 1 mm, then it is considered as a positive margin, just like rectal CRMs. So this is agreed here. So margin status can be reported as R0 when there is no residual disease, R1 positive microscopic residual disease, R2 positive macroscopic residual disease. And you can say whether it is single site or it is multiple site. So for distal pancreatectomy, there is no controversy. So it depends on the preference and the type of lesion, whether you have cystic or epithelioid region, neuroendocrine carcinoma or span. So according to that, you can give. If mucinous, then relationship with pancreatic ducts should be demonstrated, and pancreatic duct can be probed and organ opened along the duct. Now, nodes can be sampled along the pancreas and splenic hilum. They also recommended one thing: you can orange peel the pancreas after you have given the margins, so that you can isolate more lymph nodes. And spleen is sampled for completion. So coming to important points for surgeon, which was one of my topic. One thing surgeons can do is not to open the specimen before sending it for examination. They should send it in adequate amount of fixative, that is at least 10 times the volume. For biobanking, if it is done, then immediate transport to laboratory is required. And it will be very good if it can be inked in OT. The container labels and types of recession should be mentioned, and as far as possible, early transport, that is same day transport to the laboratory, should be done so that it can be cut and the tumor fixed. And it is always better to discuss the preferred protocol, because there is so much confusion in Whipple's grossing, and ask for your own reporting requirements so that it can be incorporated. So to conclude, we can accurately classify by EUS guided FNAC with FNAB or cell block, or CT guided rarely. Use of diagnostic criteria, radiological, clinical and biochemical findings has to be correlated, and gross examination is critical for accurate margin assessment with inking of the relevant surfaces. Should not ink everything, should be prudent, otherwise it becomes difficult to orient. The protocol you should be should consider surgeon's preference. If they want leap, so we can do it, but it should be discussed. A multidisciplinary approach is mandatory for best patient outcome. Thank you.
Thank you, Dr. Gupta. Very, very informing presentation. Now, I had a couple of questions here. You said it should not be inked, or it should be inked?
Where?
You said it. You said it shouldn't be inked.
No. It should be inked. But yeah. I mean, like you have anterior free surface. You should not ink everything. Otherwise, it becomes very difficult to orient the.
So we should only 2 SMA and SMV?
Yeah, vascular and uncinate should be marked.
Uncinate, you mean SMA, right?
Yeah, actually that is the confusion. Some people consider the uncinate as the posterior margin. The CAP protocols, it is same as posterior, because that is the area where actually the surgeon is set to dissect the pancreas from the retroperitoneum.
So that is SMA, sir.
That is the SMA. Yeah.
Yeah.
Because in the anterior to that, it is anterior to the uncinate process.
Yeah.
SMA.
Yeah, exactly. Yeah. And what proportion of your specimen come inked?
None. We don't get it. We don't want it, but it is. I mean, because then it will be accurate. Now.
Yeah. So this is the point I exactly wanted to bring out. We should be inking our specimens. So especially since this is a class for residents, and they are one who are left after the OT for the specimen, you should ink the specimen. That will help our pathologist give us a very good guide. And you can, Dr. Gupta, you can tell them what material to use for inking of these specimens.
See, we use synthetic dyes, which are used for this fabric colors. So they are commercially available dyes, which are slightly expensive, but we use this synthetic fabric dyes.
You can use that watercolor also, no? Which are available for kids and all that.
Watercolor will not stay actually.
Okay.
Watercolor will dissolve. So we use.
So what do I buy in the OT? Like, how do I ink it in the OT practically?
Practically,
I get dye from pathology department.
Yeah, you can get it.
Okay.
We buy all colors.
Yeah,
red, blue, green.
Can I make a point here? I'm Dr. Kavita.
Yeah, Dr. Kavita. Yes.
Yeah, actually, sir, it is good that we get inked specimens from OT, but I really feel that when our residents ourselves do that, probably the specimen gets messy at times. So is it possible the other way that can we suggest that we get a good sutured margins, like especially the retroperitoneal, the uncinate ones, if they give us 2 or 3 sutures, I mean, would that be good enough? I think inking would maybe makes the specimen more messy. I think that is just a suggestion.
Dr. Gupta, you want to answer that? Because you have to examine the specimen.
Yeah, I think both are okay if it can be sutured, especially the uncinate, because orientation of Whipples is, it is not difficult, but the margin, the real margin is the uncinate, which is rough. And it has fat where you get loose pancreatic tissue. So that is the area that is said to be most commonly involved in head of pancreas cases. So especially when you're doing a head of pancreas case, I think it will be better if it is inked or sutured.
The sutured by different 2-3 colored sutures, like they can put so that we know the exact area for the uncinate margin. Because coloring
can be easily oriented, but the rough part can be sutured. A loop or anything can help.
Correct, sir. Absolutely.
So, sir, one more question. So, like we mentioned Leeds protocol in defining the pancreatic margins. So, do you think that switching over to Leeds protocol will give us more R1 resections on, pathology reporting rather than R0? Because, most of the time it is shaving off from the SMA rather than a clear resection. So, which protocol, would you suggest is a better, whether CAP or Leeds in that matter?
See, I think Leeds you can use, but it is very extensive. You have to give, as I said, you have to start from the superior, then go on sectioning, give axial sections, then you keep all the slices, then submit them. So you will be putting a lot of sections. So that is the issue. And I think they have shown the second study that the shave margin from the uncinate with bread loafing, it is also good enough.
Yeah.
And
So
especially,
Yeah, Dr. Gupta, sorry I interrupted you.
Yeah. And what we found is, I think in our experience, I think Leeds protocol is good for HOP carcinomas. But when you are dealing with ampullary carcinomas, you have to open the ducts. You have to examine the CBD, the ampulla, before you cut the specimen. That is very important. So it cannot be used for all the cancers, the Leeds protocol. You have to modify, like you have cystic neoplasm or you have a IPMN, then you cannot use this, because then you have to concentrate on ducts rather than a solid mass. So that is a problem.
Dr. Kavita, you were asking something.
Yeah, actually, my question will be to Dr. Shefali, that now since anterior and posterior surfaces are to be definitely considered in our reporting, although they are not recommended, but we have to. So if we report that less than 1 millimeter, they are close, the tumor is close to anterior or the posterior surface, which is less than 1 millimeter, does it change your treatment? Like, do you become more aggressive?
So, I mean, close margin is of course a concern. Then close margin, we would like to incorporate radiation into our treatment protocols. Otherwise, there is controversy whether to include the radiation in hepatobiliary pancreas or give them chemotherapy in the adjuvant setting. So, of course, close margin or nodal positivity is something which we are looking forward to prevent the chances of recurrence. That is why my question to Dr. Gupta was that if you use a Leeds protocol, so the chances of getting a higher R1 rather than R0 would be there, and we can incorporate the radiation in that setting. That is why I was asking that thing.
No, but then anterior and posterior surfaces are not margins yet. I mean, I'm just asking about the surfaces, that since they have been included in CAP protocol now, so they have the same, will you go for the same, this thing, for more aggressive adjuvant or for more radiation if anterior and posterior surfaces are closer, less than 1 millimeter?
So if I understand correctly, the posterior surface, you are mentioning about the uncinate process and the SMA margin. So because one type of protocol, sorry?
So I'll just clarify a few things. I think there's a little confusion. So there is anterior surface, right? Again, then there is pancreatic neck margin, then there is SMV margin, SMA margin, and then there is this posterior surface. So anterior and posterior surfaces generally are not attached to any structure, and we don't consider them significant from the point of view of adjuvant treatment. If that answers your question, Dr. Kavita?
Yeah, that is what I
Yeah.
Because now, since they are being included in the CAP protocol, so do they actually carry any significance for the surgeon or for the medical?
No, not really.
No, not really.
SM and SMV margin, there is very soft data to suggest that they can be, if the margins are close, we can give them radiation. Yeah, but there is soft data to that effect. But so we have a couple of more questions. Dr. Rajneesh? Rajneesh, sir? Yeah, this question is for you. What is the normal cutoff used for preoperative biliary drainage? Dr. Hazarat has asked that question. If she or he is around, can ask herself. No.
Yeah, so I don't think that has one-line answer. If you're asking me, everything else is in order and only the bilirubin is to be used, then we use 20 milligrams per deciliter, but then again, that is not set in stone. There are patients we've operated on 22 as well. So very high bilirubin in the absence of any other risk factors would be a very, very controversial issue to pinpoint.
So I would ask you a question here, sir. How did you use that number 20? How did you use
that number? Well, it comes after 19 and before 21, so that's the only thing.
Because I mean, both of us are trained from AIIMS, and the cutoff we used to use there was 15.
See, what happens really is that when you start using, so you go through a learning process, and I'm sure you've been through it, I've been through it, and others will also go through it. In the learning process, you start picking up things the way they are supposed to be done, and then you realize, no, it can't be done all the time like this. So you burn your fingers, and then you start thinking, let me do it the other way around. So when you start doing things, you start stenting all of them. Then you burn your fingers by getting complications because of stenting and because of the infective complications. You start looking for patients where you can do things without stenting. And then you start pushing the boundaries from 15 onwards, because stents do cause trouble all the time. Whether you stent them at 10 or whether you stent them at 20, it is the same story. When you start pushing boundaries, you realize that, okay, there is a point to which I can go. That learning continues. Unfortunately, literature or interpersonal experiences are different. So my learning experience is that possibly I would not go beyond 20. There are people who would say I can go beyond 25 as well. And there are people who would say, no, I won't go beyond 15. Each one of us is correct, because each one of us had bad experiences by which you draw those cutoffs. But the way science progresses is that we have to put them in order of not being affected by bias. That can't be coming from this kind of a discussion. That has to come from large studies.
Yeah, definitely. So I totally agree, sir. So basically the idea is that in a good risk surgical patient, we can keep the cutoff a little higher, and in a patient who needs optimization, we will be more keen to drain the patient before operating, if that's the message which goes out. And next question was fully covered SEMS or uncovered SEMS. So Dr. Vikas said it's surgeon preference. But I think it would be the cost which will be the determining factor here. Otherwise, I don't see a difference in the outcome. What do you think, Dr. Vikas?
Yeah, cost will be same for the covered or uncovered. And there is risk of migration with the covered stent. When we place a covered stent for the short duration, you want a stenting for, I think, 2-3 weeks. Until unless you are planning the neoadjuvant, the plan is to put a stent for 2-3 weeks. So I think the uncovered, the chance of migration will be low. The issue with uncovered is the tumor ingrowth. But I don't think that should be an issue if you're placing it for 2-3 weeks only. So my preference will be.
I think that answer should be uncovered stent then, right?
Short
until
uncovered.
if you're planning to take it out.
Yeah.
Which we would.
I think that should be uncovered and 2 centimeters below the liver hilum.
Below the hilum, so that we can get a margin there.
Yes.
Do I have any other question?
I want to ask you a question. Yeah, you mentioned that the post-surgical complication increases after the ERCP. So, what are the challenges a surgeon face after the ERCP? What do you anticipate? Which complication you anticipate?
Dr. Rajneesh, sir?
Not something I anticipate. It's well documented all over the world now.
Yes.
So first thing you find is that there's a polymicrobial growth in those bile cultures all the time, almost all the time, well documented.
Okay.
And that leads to another complication, which is again very well documented, that is wound infection. So much so that quite a few of us don't even do primary suturing in a patient who's stented. Probably do a delayed primary closure of the wound, of course, based on individual unit experiences. Then comes the area which is a little controversial, which is infective complications in the abdomen, which means infective complications of collections, more PJ leaks, more septic complications of other sorts. So those are a little more controversial because some series would tell you yes, some series would tell you no. But my personal experiences have been that infective complications of all kinds rise, right? What else can go wrong? Well, the stent, especially the plastic stent, possibly because they get blocked so often, do cause a lot of inflammation around the bile duct. So again, very well documented that pericholedocytis and increased problems in dissecting the bile duct, at least in a proportion of patients, maybe not all, but very well documented, both pathologically as well as its surgery. Well, will a SEMS solve it? SEMS also causes some degree of pericholeitis, but possibly lesser than the plastic stent.
Yeah.
Okay, so I think that helps, Dr. Vikas. And Dr. Rajneesh, I just wanted to ask one more question. After a good CT scan, which are the patients you will send for endoscopic ultrasound?
Yeah, actually, I wanted to ask that to Dr. Vikas.
Yeah.
Because it seemed that, there's one thing, you're very good in your job, but science has to still take the lead, which means that if the large number of pancreatic cancers or periampullary carcinomas are getting EUS, then at some point you stop and think that at least a proportion of them did not need it before deciding on treatment. So the bottom line I draw is that I will get my EUS only if the management is going to change.
Yeah.
You might ask the question saying that If CT or MDCT gives me a staging accuracy of 85%, US will enhance it to 90%. That figure seems to be a little controversial to me, because it seems that across the literature, at least statistically speaking, there's not much difference between MDCT and US across the board. There are specific instances where US does help, where I would take help, there's no doubt, but I would not apply it across the board.
Nikhil, can I add to that?
Yeah, please.
Yeah, I think 80% of pancreatic cancer, they are once they reach us, they are unresectable. I think 70-80%, and in those we have to establish the tissue diagnosis. So in those patients, I think USFNA is definitely going to help, because we want to start patient on chemotherapy, and mostly with ultrasound we don't get the window. And regarding the 20% resectable lesions, if we are very sure with the history, ultrasound, and the CT scan, it's a malignant lesion, resectable lesion, I think you can go ahead with the surgery. On the other hand, young patient, we have seen many young patients with the lymphoma and tubercular mass. These are patients we should attempt a tissue diagnosis. On the other hand, elderly patient, classical double duct sign, CT showing the mass lesion, clearly resectable, please go ahead with the surgery. There is no point in doing the USFNA in these patients. And I think if you follow that non-alcoholic elderly patient, I think 95% should be malignant. The cutoff, the literature says it can be 5 to 15%, but I think that includes a lot of alcoholic patient also and chronic pancreatitis also. So if you have excluded the chronic pancreatitis, you have excluded alcohol also, I think more than 95% of such lesions will be malignant.
Yeah, I think that's very helpful, Dr. Vikas. Now, if I further refine the question, Dr. Rajneesh, so if you're talking about borderline resectable pancreatic cancer and CT suggests, venous invasion, would you want to confirm that on endoscopic ultrasound, or you will consider it borderline resectable and proceed with neoadjuvant or whatever protocol you prefer?
No, if CT is showing that it's involvement of SMV portal vein is there. Now there are two options: either you can directly operate or you want a neoadjuvant. Okay. If you're planning neoadjuvant, FNA is necessary actually. Before the neoadjuvant, you need a tissue diagnosis. In that, we have to do the USFNA. And second thing, if CT tells you that there is involvement of SMV and portal vein, you can take that, I think. If CTs, there is a suspicion in the CT scan, the CT confirms that there is definite involvement of SMV portal vein in the form of thrombus, or the collaterals are there, or change in contour is there, you can take it as a positive finding. Okay, if it is not known,
once we are doing USFNA anyway, so we can also have a look at the vessels at the same time, and I think that's a fair idea. Yep. And I think that brings us to the end of questions. If I have any more questions from anywhere.
Nikhil, I want to make a comment regarding the USFNA.
Please, yeah.
Dr. Gupta mentioned regarding the quality of USFNA. I don't think he's very happy with the quality of USFNA. He thinks it's a very small sample. But I can tell you, in our setting, we have a dedicated cytology department. And most of the time, I think the yield is more than 95%. Now we have good needles also. New US FNB needles are there from the Boston and the Sharpcore. The yield is really good, and you can do immunohistochemistry. You can do the genetic studies also there. So definitely we have improved on that front. You can take, now the yield is around 95%. Yeah.
Right. I was not saying that. My intention was to highlight the limitation of US for the cystic mucinous lesions.
Yeah, definitely.
Yeah. In that, the yield will be less, whatever needle is there.
I would like to mention one thing. We don't FNA the cystic lesion for the differential diagnosis. Differential diagnosis we make based on the appearance of the lesion.
Yeah, that's true.
Right? If it's a honeycombing, it's a serous adenoma, there is no need of putting the needle there. So we want to look for the malignant potential of the lesion. If it's a 3 centimeter lesion, it's a borderline chance of malignancy. Then we want to see the malignant cells in the fluid. For differential diagnosis, we send it, we do the CA and the amylase. That gives a differential diagnosis. The only intention of sending the sample to the cytologist is we want to look for the malignant cell. If it's a 3 centimeter mucinous neoplasm and you tell us there are malignant cells are there, we will send the patient for surgery.
Yeah, that is why they have done that.
Dr. Vikas, can I ask you a question?
Yes, sir. Sure, sir.
This came to attention a few days back, so I was a little surprised whether this is actually an issue or not. So when you poke a needle through the into the pancreatic mass doing a US for FNAC, do you make a specific point of going through the antrum, or you make it a point to go through the duodenum?
So only through the duodenum only. If it's a resectable lesion, we will definitely go through the duodenum only. And all the pancreatic head masses, they can be easily approached from the duodenum or the antrum, duodenum or the D1 or D2. So we'll always.
This actually surprised me because the endoscopist I was listening to said there is an option is available, and some tumors are better approached through the antrum, the other tumors are better approached through the second part of duodenum.
So if the tumor is very large, imagine it's a 6 centimeter tumor, unresectable tumor, and there is a duodenal obstruction, one is not able to go inside the duodenum, then when one can try sampling from the antrum, provided it's a unresectable lesion. But resectable are mostly less than 3 centimeter, and we don't see the pyloric obstruction. We can easily enter the first part of duodenum. Yes, we always take from the duodenum only for the resectable lesions. No doubt, no confusion there.
Thanks.
Yeah, so we are now way past our stipulated time, and we actually had very good attendance till the last mostly. So I think it was mostly informative for the residents. And with this, I would like to thank you everyone for giving us very informative session. And the next session we have in on 3rd of February, and in that we'll be talking about resectable pancreatic cancers. So that brings us to the conclusion. Thank you all. Thank you very much. Thanks for attending.
Thank you so
Thank
much.
you, Dr.
Thank you so
Nikhil.
much. Thanks.
Thank you.
Thank you, Shifali. Thank you, sir.
Thank you, sir. Thank you.
Good night.